Thank you very much. So we'll go to our next speaker, Dr. Paolo Ghia. Dr. Paolo Ghia is Professor of Medical Oncology at University at San Raffaele and Director of CLL Program at the Hospital San Raffaele, Milano, Italy. He received his MD from University of Torino, Italy, and his PhD working at the Basel Institute for Immunology in Switzerland. He did his postdoctoral training at the Dana-Farber Cancer Institute, Harvard Medical School, where he's currently visiting professor also. He is president of the European Research Initiative on CLL, ERIC, treasurer of the International Workshop on IWCLL, the co-author of the EHA ESMO guidelines for CLL and the ERIC recommendations on IGHV, TP53, and MRD. And it's a very important question that would like to hear from you is, do we have enough evidence that combination is better than sequence in CLL?
Thank you very much for the introduction. Thank you very much also for the invitation. And thank you also to Dr. Visentin and Allegazzi, who really introduced the field of novel treatment in CLL. So for me, it will be much easier. And I will not talk about science today, but about science fiction somehow. So I'm trying to answer this question. Do we have enough evidence for combination compared to prefer combination compared to sequencing CLL? These are my disclosures, and they are actually also helpful because, as you can see there, all the companies that are involved in CLL treatment are listed just because we have been involved in the development of each of these new drugs and the combination. And the important message is that whatever we do in CLL in 2024, it's always good, I would say. So compared to the immunochemotherapy period, nowadays it's difficult to make mistakes. All the treatments, all the combinations, all the strategies are very effective. Of course, now we are becoming a little bit more picky. So we want to go cherry picking, and therefore we want to refine the best strategy in each of our patients. Also because now we learn, and here I show you the data for ibrutinib, but it would be probably the same with acala and zanubrutinib. So with BTK, continuous BTK inhibition, we publish and show that patients nowadays can expect a life as long as any other unaffected individual, both individuals below 65 years of age, young, or above 65 years of age, old patients. So this is a success, and this can be achieved with continuous treatment, and maybe many patients, one treatment will be enough for their life. So we don't need to talk about sequencing, second treatment, and so on and so forth. But still, we know that this is not, it's science fiction, but it's not fantasy, so it's true that we are not curing anyone. Many patients still relapse. We have double refractory. We have patients who need treatment. So we try to improve what we are doing in our patients. Anyhow, you already saw this, the data on continuous treatment with BTKIs. Here again, ibrutinib, because we have 10 years follow-up. The other drugs have been developed, calabrutinib and zanubrutinib later on, so we have only 5 or 6 years follow-up, but the curves look very similar. And we know that we have very long-term disease control, also in patients with high-risk feature, unmutated immunoglobulin genes, but in particular also patients with P53 aberration. But still, we wanted to move on towards combination with the idea of achieving a fixed duration treatment, a time-limited treatment. And this because, of course, with the time-limited treatment, we want to limit the adverse events, and in particular, as a lab researcher, as you heard, working in the lab, I'm really concerned about the clonal evolution. So keeping the cells, the leukemic cells, under pressure by the therapy, we are selecting worse disease. When the patients relapse under continuous treatment, we have really difficult to treat diseases. Of course, also the decreasing financial cost is always welcome. So we have a couple of, you already heard, you know everything about this. We have a couple of combinations that we can use, the Venobi, venetoclax obinutuzumab, very, very good results, 6 years of follow-up, 6 years of the PFS at 6 years is roughly 50%, so we can expect 5 years in every patient in median. 5 years of therapy after 1 year of therapy. There are nuances in patients with high-risk features, so those with P53 aberrations are definitely progressing earlier. Those with unmutated immunoglobulin genes are also progressing earlier, but still after 5 years median. So it's still a reasonable, very good achievement, thinking that the patient has been treated only for 1 year out of the 5, and then we have the possibility of retreatment. I plus V, venetoclax plus ibrutinib is the other combination, BTKI plus BCL2. We will hear at ASH the results of the Amplify, acalabrutinib plus venetoclax. I presented the data of zanubrutinib plus venetoclax at EHA a few months ago. And again, these are all combinations that have a rationale, and based on the results that I show you here of the Captivate study, venetoclax plus ibrutinib in young patients, this combination is also very effective. All treated, this is a follow-up at 5 years. All treated patients there, you can see 2/3 of patients are still responding, not relapsing after 5 years of follow-up. Patients with p53 aberration are doing a little bit less, 47% only responding at 5 years, but still it's 47%. So 50% of the patients, despite having p53, are still responding after 5 years. So 15 months of treatment and almost 4 years of therapy. If we look at patients with unmutated immunoglobulin genes, here we have probably even an improvement, meaning the patient with unmutated immunoglobulin genes, they are 68%, so more than 2/3 of the patients will be responding after 5 years. So this is something, again, very, very welcome in our patient. And this translated in the new ESMO guidelines that we just published a couple of months ago, where indeed we put a lot of attention and we underscore that the first option should be in every category of patient except those with p53 aberration, should be combined treatment, should be fixed duration, because even with similar efficacy or even with a lower, potentially lower efficacy, the fixed duration treatment is preferred by assumption that we are doing something good to the patient, we are preventing clonal evolution, we are preventing the occurrence of resistance, so we allow the patient to reuse the treatment several times, hopefully, in their life. But still, this is my answer to the question that was posed, we don't have enough evidence. So these are all wishful thinking. We, again, as I said, science fiction. We try to see the future, but we don't know because we are still missing the results, in particular because the responses of the first-line treatment are so long that it takes a really long time before we can understand what is the value or of the sequencing treatment or the additional retreatment and so forth. But I'm trying to, again, as I said, to extrapolate a little bit. Next year, 2025, we will have the results of the CLL-17, that is an international study coordinated by the German CLL study group, comparing ibrutinib, continuous treatment, to venetoclax obinutuzumab, 1 year of treatment, and to ibrutinib plus venetoclax, 15 months of treatment. So what's going to be the result? I can tell you that very likely the result is quite clear. I mean, the continuous treatment will win. I mean, how can you beat 10 years or 9 years of median PFS when you have with venetoclax ibrutinib or venetoclax plus obinutuzumab something like 7 years altogether? But here we are talking about PFS1, so the first progression. And this is what we have to change our mindset for the future, because PFS1 is not so relevant at the end of the day. So we want to know what happens after the first treatment, because we know that we can bring the patient to a second treatment, even to third treatment. So that's a key point. And there the situation becomes a little bit trickier. So if we look at PFS2, so the time of the second progression starting from the treatment, then the situation looks a little bit different. I would say that after continuous BTKI, we have venetoclax, we have venetoclax plus rituximab, the Murano approach, but it's not so effective at the end, because the data from the Murano were in patients who did not receive BTKI, who were mainly second line after bendamustine plus rituximab, and there we had very beautiful 5-6 years progression-free survival. This is not going to happen in patients after failing, becoming resistant to continuous BTKI. Not talking about intolerant, this is not the topic, but after failing the continuous BTKI. And after that, maybe you can have some time of therapy, which is not going to last long, and then you are already in the non-covalent BTKI world, or even CAR-T, bispecific experimental therapy. When you do a fixed duration treatment, there is the possibility, as I'm going to show, that you can have a long period of therapy and then you start your continuous BTKI. Again, we don't know there how long, not probably 10 years as we did in first line, but even 5 years would be already quite a good period, and that would lead you eventually after another 5 years to maybe non-covalent experimental therapy and so on and so forth. When you think about venetoclax plus obinutuzumab, you can think of reusing the venetoclax combination with the antibody for several times, maybe just one, and then you move even further down the line, the time of relapse and the time of ending your standard options. But also for venetoclax plus ibrutinib, you can think exactly the same thing. We don't have data, again, on the use of venetoclax-based combination after venetoclax plus ibrutinib, but you can think, and again, we are in the science fiction field, then you can again reuse for a short period venetoclax-based combination of therapy, and again, then postponing the use of continuous BTKI. And there, really, I mean, I'm not going to see the results of all these studies, and even in the real world, I'm not going to see my patient at that point after probably 15 years of follow-up. So what do we know? We don't know much, but we know we're starting collecting some information. So after ibrutinib plus venetoclax in the Captivate study, we know that we are not allowing resistance mutation to occur, not to BTKI, not to BTK, PSC gamma 2, not to BCL2. There was only one patient who had a mutation, which is not a typical mutation in BCL2 leading to resistance. It was a mutation that was already present at the beginning. The patient responded very well, and then responded also at relapse, again, always having the same mutation, which is functionally irrelevant. What we know that we can retreat the patient. Most of the patients have been retreated with ibrutinib alone because that was felt safer by the physician, even if they were allowed to reuse ibrutinib plus venetoclax. Now some patients, 7, we are going to present more at the next ASH, are also being retreated with I plus V, so again a fixed duration treatment. That's the goal. When we start in frontline a fixed duration treatment, we want to continue with a fixed duration treatment because that's the idea, to give off-therapy period, drug holiday to our patients. It's a nonsense somehow to start immediately a continuous treatment upon relapse. It means that you are somehow concerned about the fixed duration treatment. So, but we don't have results. We have now a median time on retreatment 21, 22 months, so almost 2 years. Patients are responding, so we might think that the median progression-free survival will be at least 2 years or something like that. After venetoclax plus obinutuzumab, for example, we have really nothing. We have the Revenge study that it's the retreatment with Ven/Obi, and hopefully we will see the results. We can extrapolate information, but as I said, this is very difficult to be done because Murano is a study that was in patients not exposed to any novel therapy, only after chemotherapy, so we cannot understand much. Definitely, we are not going to have 7 years of a median of 5-6 years upon retreatment. Maybe yes, because the patient did not have immunochemotherapy, so they didn't have any DNA damage, no clonal evolution. We don't really know. We know that after Ven/R, venetoclax plus rituximab, after the Murano, but here we're talking about third line, we can reuse venetoclax plus rituximab, and you have a median PFS of 2 years. So you would expect that in second line you would have at least 2 years, definitely much more, but we don't know. But just to tell you that the horizon and the perspectives are definitely much brighter than these 2-3 years that we saw in the past. Having said that, just to make things more complicated, and then I go to conclude, this is a nice paper review by John Seymour. I mean, I showed you just an example of sequencing, but then you can play your cards as you want. So maybe after fixed duration, you want to go for continuous treatment, which I doubt, but because there you would really select clones, but it's a possibility, and then reuse the fixed duration later on. Maybe you want to, when you start continuous treatment and the patient relapses, you want to continue and exhaust the fixed duration, the continuous treatment option using the non-covalent BTK in second line, even when, if and when they are approved, and then move the fixed duration treatment at the end of the line. Maybe you want to mix the different strategies in order to eliminate the resistant clone more efficiently, and maybe you make the patient become again responsive to the initial therapy. So these are all scenarios that we don't know, and that will really modify how sequencing will be effective or not. With that, I just want to conclude, because this is only the approaches that we have now, approaches that are meant to improve the quality of life of our patients, so to give as little drug as possible and to give a lot of drug holidays. But there are other colleagues, Peter Hillman and the British colleagues, Tal Munir, they are advocating in favor of that, of curing the patient. Give one treatment once in their lifetime and then never again. In that case, of course, you have to use MRD, and you have to do longer duration. So that's the point. So we are in between a continuous treatment and a short fixed duration treatment. And that's the FLAIR study. We already heard about that. And the strategy is that you have to continue the treatment as long as for the double of the time that the patient needed to achieve undetectable MRD. And that can be up to 6 years. So we are almost in the range of a continuous treatment. Having said that, the results are great. 97% of patients after 3 years not yet progressing. So it's possible some patients are maybe functionally cured, but still it's true that probably they will have only one treatment in their lifetime and they will not need much else. But 5 or 6 years of treatment. Having said that, I want to thank you. And if you have any other answer to the question, I'm happy to discuss. And these are all the people working in Milano, in Greece, my long-standing collaboration, Kostas Stamatopoulos, and the Dana-Farber, where I'm currently visiting. Thank you very much.
Thank you very much, Dr. Ghia. Do you have any questions from the audience?
Everybody convinced?
Okay. I can just quick, there is one question, please. Go ahead. Please introduce yourself also.
Dr. Ahad, Hematology Fellow in Dubai. My question is that you mentioned that if the patient received VEN as initial therapy, then the subsequent therapy with the BTK is less likely to be responsive because they were exposed to VEN before. But if the patient was started and then they did not respond to the therapy, would you go to a BTK as a second line? Does it stand true or more stronger that?
So I have to say that in front line, to find someone primary resistant is very difficult. I remember that within the ERIC we launched even a project on primary resistant to ibrutinib or BTKI. It's very difficult. It's true that there are patients who respond only a couple of years, and that's bad. I mean, it's not definitely optimal. It's difficult to find a primary resistant patient in that sense, really, that it doesn't respond in other. Of course, you will move to another therapy, but that I would probably go back and check the diagnosis, for example, because that could be also sometimes a typical CLL, and it turns out to be a marginal zone lymphoma or something else. Yeah.
And another question, if the patient received a fixed duration therapy and then they relapse, like after 2 to 4 years, for example, would you go for a repeat fixed duration therapy?
Yes. What we wrote in the new ESMO EHA guidelines is that at least 3 years of response before retreatment. So I would say 4 years, I would feel confident to do it. It really depends on the quality of the relapse. So at the end of the day, why not to try? I mean, you are not losing your patient. It's not an acute leukemia. It's not an aggressive lymphoma. You can always try and then decide later on, I'm going to stop or I'm going to continue. You know that anyhow in those patients, you can always recover them with the continuous BTKI. So if you are not convinced, you can keep the BTKI and you're safe and you will maintain the control of the patient.
last question.
Yes.
Would it make a difference to give them VR compared to VO?
VR and VO in the relapsed refractory setting?
And when they relapse, like after
When they
3 to 4
relapse, yes. We do, as we heard from the colleague from Barcelona, we do what the regulatory agencies allow us to do. And as I said, I'm visiting in the US. It's a completely different world. They can do it, and they do it. So they use venetoclax plus obituradine in second line. Of course, it makes sense. There is no data, but it makes sense. We are not allowed. So I have no experience at all in using Venobi in second line.
I think.
But if you are allowed, yeah, why not?
Okay, we'll read the last note and then maybe I can shift.
Thank you very much. Where is the place of allogenic transplant and all these CLL therapies nowadays? We see a lot of young patients here in this society, and many of them have donors. Where do you put allo transplant with these pathways now?
Yeah, difficult choice. We say it by the book after failing the first inhibitor. So if you fail a young patient who fails a BTKI, in particular if failing after 2-3 years of treatment, 4 years of treatment, that's a patient where you should really discuss the allo transplant. Again, nowadays it's even much more difficult. The CAR T, unfortunately, are not working so well, but still are becoming one option just to try. The issue is always that on one side, allogeneic transplant is 15%, 20% of treatment-related mortality. Next month, you are not here. And on the other case, even the worst patient with CLL will have months, and then you have always some experimental drugs. So it depends if you have access to novel drugs, BTK degrader, bispecific. They look working quite nicely, even in Richter transformation. So it's a difficult choice. I have to say that I probably did not advise anyone for allo transplant in the past 5 years.
Would you consider
But it depends also on the availability, of course, as I said, access to novel drugs, and otherwise, in many countries, like when I talk in Latin America, it's an option, it's there. They don't have, in many cases, they don't have access to even antibodies sometimes.
Sometimes we wait on some patients because they're responding and so forth, and at one point they just transform into a large cell lymphoma, and you would think, oh, should I have done a transplant earlier?
No.
Yeah.
First of all, the transformation happens. It's not so frequent, so always make sure to have a good histology, because many cases that are called diffuse large B-cell lymphoma are at the end accelerated CLL, which are more aggressive, which are PET positive, but they do respond to the same therapies as the CLL. So if there is diffuse, you cannot prevent. Remember always, you cannot prevent Richter transformation. Whatever you do, it will induce more frequently Richter transformation, which is a complication after treatment in particular. We have patients also who can develop it treatment naive, but the vast majority are after treatment. So don't think you can prevent it, and that can happen. Yeah.
Just, I think, on the follow-up of the same question, if you have a very high-risk patient with 17p deletion and he fails a fixed duration therapy of a combination of ibrutinib or acalabrutinib with venetoclax, why retreat them when you know that the remission is going to be shorter than the first time? Why not take them to allo transplant at that time?
No, in fact, absolutely. It's an option. I have to tell you that, again, I am a referral center. I see probably the worst of the worst in terms of patients, and also young patients. Fortunately, they are rare, okay? So patients that relapse and they are still young enough to be transplanted and have the donors. So it's a discussion.
We have patients who are in 30s and 40 years old with 17p and CLL are failing. So
I don't, though I made my career on markers, I never define a patient by the markers. I always define them by the clinical presentation and response. So let's see first how long it will respond and how fast it will relapse, and then we discuss. It's an option, definitely. We always discuss. many patients don't accept the risk.
Thank you very much. I think we'll move to